Hello everybody and welcome to another video on my channel Internal Medicine Algorithms and Mnemonics. It's Ryan here. As you can see, I got a handy t-shirt today. Registered doctor here to examine you. Okay, today we're talking about the hodgepodge alphabet soup that is interstitial lung disease, which is now no longer called interstitial lung disease. It's called diffuse parenchymal lung disease, DPLD. All right, so we're going to start off with the clinical case, and then we're going to dissect diffuse parenchymal lung disease, talk about the definition, the clinical features, the pathophysiology, types and classification, investigations in way of imaging, how do we diagnose, approach to management, prognosis, and of course, encouragement from the Bible thereafter. Fasten your seatbelts, guys, because this is a topic which tends to be a little bit cumbersome and confusing. So, we have a 62-year-old man who is evaluated for dyspnea on exertion. Let's just get my pointer in there, which has progressively worsened over a period of 10 months. He has a 50-pack-year history of tobacco smoking, having quit 10 years prior. On physical exam, he has a resting oxygen saturation of 94%. After ambulation to 100 meters, his SAT drops to 84%. He requires oxygen at 3 liters per minute to maintain his saturation at greater than 90% with ambulation. Alrighty, his lung exam shows diffuse inspiratory crackles throughout both lungs. His total lung capacity is 72% predicted, residual volume 68% predicted, and diffusing capacity for carbon monoxide, 60% predicted. The HRCT is shown alongside. We'll have a look at it just now. Serology for autoimmune disease is unremarkable, and thorough history yields no exposures that will lead to these findings. You suspect idiopathic pulmonary fibrosis. What is the expected finding on surgical pathology? Nice to ask, right? Is it A? Let's just have a look at that CT. There's our handy CT, okay? So your options are A, desquamative interstitial pneumonia, B, diffuse alveolar hemorrhage, C, loosely organized granulomatous inflammation and fibrosis, D is NSIP, which is non-specific interstitial pneumonia, or is it E, UIP, which is usual interstitial pneumonia? Guys, let's get stuck into this hodgepodge topic. What is really diffuse parenchymal lung disease? It represents a heterogeneous group of diseases characterized by diffuse injury and inflammation that can then progress to lung fibrosis. It was previously termed interstitial lung disease. And the reason why the nomenclature has changed is because, as we know, this is the interstitium, right? Let's just get my pointer in there. So as we can see, the interstitium is composed of not just the collagen around the alveoli, but also includes the alveolar space, the air space. So whereas we have the type 1 and type 2 pneumocytes, right, which are part of this barrier that forms the barrier between adjacent alveoli, right? The term interstitial lung disease implies that disease is confined only to the interstitium, when actually it includes the alveolar space as well. Hence, the nomenclature has changed from interstitial lung disease to diffuse parenchymal lung disease already. And so we say this term is preferred as opposed to ILD because the pathology involves the alveoli together with the interstitium. So what history is important in the context of diffuse parenchymal lung disease? Well, firstly, ask about the onset of disease. Is it something acute, or is it something more chronic, running a more grumbling, insidious course? Then you want to inquire about history of connective tissue disease, because a lot of diffuse parenchymal lung disease is associated with rheumatological conditions. The forerunners being rheumatoid arthritis, systemic sclerosis, dermatomyositis, systemic lupus erythematosus. So questions you want to ask about is joint pain and joint stiffness, notably early morning stiffness. All right, we're going to talk about joint swelling. We're going to talk about a diminished function of the joints, especially the hands, okay? We talk about change in the color of the fingers, alluding to Raynaud's phenomenon, white, blue, red, the triphasic color change. We're going to talk about any rashes, any Zika symptoms, any oral ulcers or alopecia, right? As well as any difficulty with walking upstairs or waking up from a seated position or reaching up for objects on a high shelf or hanging up close. It speaks to proximal muscle weakness, weakness of the pelvic and the pectoral girdle. All right. Those are the telltale symptoms you want to talk about, right? Of course, history of bleeding as well, which implies thrombocytopenia, history of pleuritic chest pain, which may imply pleuritis, okay? History of drugs and smoking is always important. Occupational and environmental history, because there are a lot of occupational exposures and environmental exposures which can lead to diffuse parenchymal lung disease. So what are the varied presentations of diffuse parenchymal lung disease? It's usually amongst elderly folk. It's somewhat uncommon in those below the age of 50, right? The cough is usually dry, right? You get progressive dyspnea, which is usually exertional, accompanied by arthralgia and arthritis, weakness and dizziness, cyanosis because of diminished gas exchange, because the interstitium and the alveoli are both involved. Digital clubbing, but only in 20 to 50% of cases, right? Looking at the pathophysiology of diffuse parenchymal lung disease taken from Pathophysiology of Disease, right? So by and large, I mean, there's four main pathophysiological processes that we speak of, all right? It has to do with decreased lung compliance, right? Decreased lung volumes as a consequence of diminished lung compliance, right? Disturbances in gas exchange and pulmonary arterial hypertension. And there's a lot of contributory factors under those four headings, right? So decreased lung compliance because the lungs are stiffer, more resistant to expansion. The lung compliance curve is shifted downward and to the right, which doesn't favor offloading of oxygen. Static recoil pressure is increased as the total lung capacity is affected and the work of breathing is increased, right? Diminished lung volumes, as we said, disturbances in gas exchange because of the fibrosis, which leads to inhomogeneity in ventilation, right? There's unfavorable ventilation perfusion ratio. Hypoxemia is typically exacerbated by exercise, right? Pulmonary arterial hypertension because of decreased pulmonary capillary surface area, increased pulmonary vascular resistance from the reduced functional residual capacity, the inhomogeneity of ventilation causing regional alveolar hypoxemia with consequent hypoxic pulmonary vasoconstriction and marked exacerbation with exercise owing to inability to recruit new vessels. So by and large, everybody, diffuse parenchymal lung disease is divided into 6 main groups. When we think about it, we think about 6 main groups. Firstly, there's granulomatous diffuse parenchymal lung disease, and the poster child for that is sarcoidosis. Then we get granulomatous diffuse parenchymal lung disease with vasculitis, and they will talk about our 3 ANCA-positive small vessel vasculitic syndromes, being GPA, which is granulomatosis with polyangiitis, previously termed Wegener's granulomatosis. Then we have its close brother in arms, eosinophilic GPA, which is previously termed Church-Strauss syndrome, and then, of course, microscopic polyangiitis as well. The third group is that of the idiopathic interstitial pneumonias, right, of which the poster child is idiopathic pulmonary fibrosis, IPF, which is previously called cryptogenic fibrosing alveolitis. That happens in 90%. Then we got idiopathic interstitial pneumonia other than IPF, which accounts for the other 10%. And here we have a lot of hodgepodge alphabet soup: desquamative interstitial pneumonia, acute interstitial pneumonia, non-specific interstitial pneumonia, respiratory bronchiolitis, boop, boop, there it is. This is bronchiolitis obliterans organized pneumonia. Now the nomenclature has changed to cryptogenic organized pneumonia. So COP instead of boop, right? And of course, lymphocytic interstitial pneumonia. Then the fourth group is pulmonary autoimmune rheumatic disease. And the main ones there, the forerunners, rheumatoid arthritis and SLE. We don't forget about dermatomyositis, polymyositis as well. Drugs which cause diffuse parenchymal lung disease, the likes of busulfan, bleomycin, methotrexate, nitrofurantoin, amiodarone. And of course, the sixth group is other forms of diffuse parenchymal lung disease, the likes of histiocytosis X, which was previously called Lange cell histiocytosis. Goodpasture syndrome is where you also, the telltale symptoms would be hematuria and hemoptysis, right? Idiopathic pulmonary hemosiderosis, diffuse alveolar hemorrhage, lymphangioliomyomatosis, otherwise called LAM, which is also one of the features of tuberous sclerosis. Watch out, right? And pulmonary alveolar proteinosis, right? An easier way probably to think about those different groups of diffuse parenchymal lung disease is to fit them into either one of these 4 categories as outlined by Pathophysiology of Disease. So you got the idiopathic interstitial pneumonias, you got the diffuse parenchymal lung disease of known cause, you got other forms of diffuse parenchymal lung disease, and then you got the granulomatous friends, right? So under the idiopathic interstitial pneumonia, like we said, IPF and then of course the idiopathic interstitial pneumonias other than IPF, we talked about our alphabet soup hodgepodge, all of those: diffuse interstitial pneumonia, respiratory bronchiolitis, acute interstitial pneumonia, cryptogenic organizing, non-specific, and lymphocytic interstitial. Then we got the DPLD of known causes, where we bring in the collagen vascular disease like scleroderma, the drug-induced like amiodarone, busulfan, bleomycin, the occupational like coal workers pneumoconiosis, the environmental like asbestosis, the granulomatous of which we say sarcoidosis of unknown cause, and those of known cause, which is hypersensitivity pneumonitis, and then other forms of diffuse parenchymal lung disease, like lymphangioliomyomatosis, LAM, eosinophilic pneumonia, and of course pulmonary lung cell histiocytosis. Guys, I have a separate video looking at an algorithmic approach to interstitial lung disease where we cover the approximately 26 causes, and here we split them into idiopathic and secondary flavors. Secondary we split into exposure and systemic disease related. So the idiopathic form is, like we mentioned, idiopathic pulmonary fibrosis, NSIP, cryptogenic organizing, lymphoid interstitial, acute interstitial, and chronic eosinophilic. Then under secondary exposures, we talk about iatrogenic in the way of medication, radiation, hypersensitivity in the way of farmer's lung, which is thermophilic actinomycetes, and bird fancier's lung. Then we talk about pneumoconiosis in the way of silicosis, coal workers pneumoconiosis, and asbestosis, and others is respiratory bronchiolitis associated ILD, desquamative interstitial pneumonia, pulmonary Lange cell histiocytosis, and drug users. Then the secondary systemic disease has to do with mainly your rheumatological conditions and some sarcoidosis, scleroderma, rheumatoid arthritis, dermatopolymyositis, SLE, Sjogren's, mixed connective tissue disease, and vasculitis. Okay, so Harrison's gives us a nice table illustrating the common DPLDs, the diffuse parenchymal lung diseases, and partitions them based on specific headings, right? So let's just get my pointer in here. They classify, sub-stratify them based on clinical symptoms, physical exam findings, exposures, findings on HRCT, histopath, and clinical costs. So I just want to talk about a few of these. So in terms of idiopathic pulmonary fibrosis, this has a gradual, grumbling, insidious onset of dyspnea. It's unusual in younger adults, usually hits the older folks. On physical exam, you're going to find rales and clubbing. Exposures is idiopathic, but stays in an association with smoking. And genetic findings may explain some 1/3 of the risk of disease. HRCT, the main things you're going to find is bilateral subpleural reticular changes prominent in the lower posterior lung zones with traction bronchiectasis, honeycombing, classic UIP pattern. So you think IPF, you think usual interstitial pneumonia. Histopathology is going to show you fibroblastic foci with temporal and spatial heterogeneity and honeycombing, right? Clinical costs, the mortality is not good, 50% 3 to 5 year mortality. Right, as opposed to non-specific interstitial pneumonia, right, which runs a more subacute onset of dyspnea, once again dry cough, frequently associated with other conditions. Physical examinations with frequent rales. Clubbing is less common versus IPF. Exposures can be idiopathic, but you should always think about other associated conditions, all right? HRCT findings is vastly different compared to IPF, because here we see, and the buzzword here is ground glass, peripheral subpleural ground glass, and reticular patterns. Traction bronchiectasis is common, but honeycombing is rare. So more honeycombing in UIP, IPF story, less honeycombing in NSIP. HRCT is not diagnostic. Right, histopathologically speaking, there's cellular or fibrotic pattern of NSIP, which is more uniform than a UIP pattern, but tends to 18% 5-year mortality, is even worse than IPF. Okay, guys, and then we also speak to sarcoidosis, systemic sclerosis associated ILD, and respiratory bronchiolitis associated ILD. Okay, so what are the investigations if you're suspecting diffuse parenchymal lung disease? First up, good to start with your hematological investigations, so a full blood count. Remember that this more than likely is an inflammatory condition, so erythrocyte sedimentation rate may be high, polycythemia somewhat rare. Okay, so you may have lymphopenia in the setting of sarcoidosis, which can cause immunoparesis, right? Eosinophilia, if you're thinking about pulmonary eosinophilia and drug reactions. Neutrophilia when it comes to hypersensitivity, pneumonitis. Then, of course, good to start with the normal PA chest X-ray film. So initially, the story is that you're going to see ground glass appearance. You may see bilateral reticular nodular shadowing, mainly in the lower zones. Lung size are reduced. Lung sizes are reduced. Diaphragm may be raised. In advanced stages, you may actually appreciate the honeycomb appearance on the X-ray. But the money-throwing main investigation, everybody, is a high-resolution CT scan of the chest, a high-resolution CT scan of the chest, which is very sensitive and helpful in earlier diagnosis, even before chest X-ray. Okay, so Harrison's gives us a guideline in terms of the different appearances of DPLD on the HRCT. So picture A here shows us idiopathic pulmonary fibrosis IPF. The classic findings include a posterior basal predominance of subpleural reticular markings and more advanced features of pulmonic fibrosis, including traction bronchiectasis, right, and honeycomb. So here we can see a nice, beautiful area of honeycombing, traction bronchiectasis, And this constellation of findings is what we affectionately term usual interstitial pneumonia, UIP pattern. Now compare this to picture B, which is called non-specific interstitial pneumonia. And the chest CT findings here may overlap with the UIP pattern, but the classic thing is that it's usually bilateral, symmetrical pattern that presents with a greater percentage of ground glass opacification. Ground glass opacification, like you're looking through someone's bathroom window, you know, that opaque kind of glass appearance. And more so apparent in NSIP, right? That's the classic thing. Additional unique findings include more diffuse imaging abnormalities with the predominance not limited to the lung bases, right? So it's not limited to the lung bases as per IPF, but you can see it's more kind of diffuse. And they tend to spare the subpleural regions. And there's thickening of the bronchovascular bundles as apparent in the right middle lung zone here. Alrighty. Then picture C shows us cryptogenic organizing pneumonia. And here we have patchy, sometimes migratory subpleural consolidative opacities, often with associated ground glass opacification. Peribronchiolar or perilobular opacities or perilobar opacities can be present, and sometimes a rim of subpleural sparing, often referred to as the reversed halo or atoll sign, which can be seen helps to aid the diagnosis. So sarcoidosis is shown in picture D. It has a varied imaging abnormalities, but a pattern of mediastinal and hilar lymphadenopathy. So the key thing here is mediastinal and hilar lymphadenopathy, okay? Other findings include diffuse small nodules in the miliary pattern, large nodular opacities, extensive ground glass infiltrates, mosaic attenuation suggestive of small airway involvement, and in more advanced cases, signs of pulmonary fibrosis. So other things you want to do to investigate diffuse parenchymal lung disease, everybody, from a functional physiological perspective, is a PFT, pulmonary function test, when you're going to find a restrictive pattern in that the forced vital capacity and the forced expiratory volume in 1 second are both proportionately low. But when you look at the ratio is actually normal to high. Lung volumes are reduced, but may be paradoxically preserved in patients who have concomitant emphysema. You have reduced carbon monoxide transfer. Your DLCO is reduced because it involves the interstitium. The pathophysiology is at the level of the interstitium, and peak flow may be normal. Arterial blood gas, often the situation is that of hypoxemia with a normal or low PaCO2, which speaks to hyperventilation. On and bronchoalveolar lavage, the bowel will show an increased number of cells, particularly neutrophils and macrophages. It may be the situation of increased lymphocytes and sarcoidosis, extrinsic allergic alveolitis, and drug-induced lung disease. All right, the investigations go on, everybody, and other investigations according to what you suspect to be the cause. The C-reactive protein may be high, symbolizing or speaking to inflammation. LDH, lactate dehydrogenase, indicates disease activity. For sarcoidosis, the other telltale things that you may look for, the calcium, serum calcium is high, urine calcium excretion and liver biopsy may be useful. Serum angiotensin converting enzyme is an indicator of disease activity, and gallium scanning may be done as well. For autoimmune disease, you're going to look for your autoimmune serology. So your rheumatoid factor, anti-cyclic citrullinated peptide, anti-CCP for RA, which is rheumatoid arthritis, rheumatoid factor and AF. So rheumatoid factor is actually positive in 30% of cases of diffuse parenchymal lung disease in low titer. And of course, hyper-gamma-globulinemia. For confirmation, lung biopsy is definitive, done in selective cases if your diagnosis is uncertain. What are the different ways to do a lung biopsy? Well, you can go transbronchial, which is via the bronchoscope, video-assisted thoracoscopic, which is the term VATS lung biopsy, and open lung biopsy in some cases. Please note that lung biopsy is certainly not a routine investigation. It's done only in select cases, and the typical clinical features in HRCT are sufficient for diagnosis. However, lung biopsy is strongly indicated if you have a young patient and you're unsure of diagnosis. Guys, principles of management of diffuse parenchymal lung disease. First up, smoking cessation. That applies to everybody. Right, avoid your air pollutants like dust and fumes. Control infection with appropriate antibiotic. Treat the primary disease if there's any primary disease. If there's a rheumatological issue, especially, you address that. Bronchodilator in the way of short and long acting. So short acting salbutamol, ipratropium is anticholinergic. Long acting anticholinergic tiotropium, right, which is terms by Riva. Then long acting beta agonist in the way of salmeterol, formoterol, oral theophylline in some cases. Prednisone. So prednisone 0.5 milligram per kg with azathioprine for steroid sparing effect 2 to 3 milligram per kg. Give the prednisone for at least 2 months, then taper to a maintenance of 10 to 12.5 milligram daily. Antifibrotic therapy, especially if dealing with IPF, look at pirfenidone, N-acetylcysteine, sildenafil, right, which is phosphodiesterase, I think 5 inhibitor, bosentan, which is an endothelin receptor antagonist, etanercept, which is an anti-TNF monoclonal antibody, single lung transplant in young patients at advanced stage. So remember, survival to 1 year in about 60% of cases. So it doesn't have that great prognosis. So the prognosis in diffuse parenchymal lung disease, we said usually 3 to 5 year survival in 50% of cases, up to 65% in a steroid responder and up to 25% in a steroid non-responder, right? What are the complications in diffuse parenchymal lung disease? To mention a few: pulmonary hypertension, cor pulmonale, chest infection, and bronchial carcinoma. Okay, guys, coming back to our clinical case, right? Just to summarize, we have an elderly gentleman. He comes in with dyspnea, which has progressively worsened over the last 10 months. He has a 50-pack year smoking history, but now he stopped smoking. At physical exam, he's testing oxygen sats 94% room air, but after he walks 100 meters, his sats drops to 84%. He requires 3 liters per minute to maintain oxygen sats greater than 90% with ambulation, so he needs domiciliary home oxygen. His lung exam demonstrates Krebs throughout both lungs. Total lung capacity 72% predicted, residual volume 68% predicted. DLCO is down. So he has a restrictive pattern on LFT. DLCO is down. HRCT is shown. Histology for autoimmune disease and exposures are negative. You suspect IPF. What is the expected finding on surgical pathology? Nice to ask, nice to ask, nice to ask. It's going to be usual interstitial pneumonia, right? UIP pattern. Now, we said that idiopathic pulmonary fibrosis, IPF, is by and large the most common cause of idiopathic interstitial pneumonia. And as we saw on the HRCT, we typically have interstitial fibrosis that is worse at the bases and begins subpleural, often associated with the two buzzwords traction bronchiectasis and honeycombing. Atypical findings that would prompt one to think of something else as the diagnosis are the presence of ground glass infiltrates, more NSIP, nodular opacities, upper lobe predominance of disease. Because remember, IPF hits the lower zones, right, the bases, and the prominent hilar or mediastinal lymphadenopathy. Bronchoscopic biopsy is insufficient for histological confirmation, and a surgical lung biopsy is required for definitive diagnosis. And the histological hallmark on the biopsy is UIP, but can also occur in rheumatological diseases and due to secondary exposures. Okay, my friends, I want to talk today about diligence, right? Diligence. 2 Peter 1 verse 10 says, therefore, brothers, be even more diligent to make your call and election sure, for if you do these things, you will never stumble. All right, 2 Peter 3:14, therefore, beloved, looking forward to these things, be diligent to be found by him in peace without spot and blameless. Indeed, God has blessed us with time. God has blessed us with giftings. God has blessed us with wisdom. And I pray that we will be diligent at whatever we say and do. Be hardworking, be industrious, apply yourself, and yield yourself to the Holy Spirit, and He will bless the work of your hands. Okay, these are my references. I'll see you soon with another topic in pulmonology. We're going to be talking about pneumonia soon. Looking forward to that. God bless you. Thank you for your continued support on this channel. You can find me on Facebook. Just search for Internal Medicine Algorithms and Mnemonics. I'm also on Instagram as well, Internal Med Algorithms and Mnemonics. God bless you. Have a fantastic day. I'll see you soon.